Well, welcome everyone to this session, which is being chaired by myself. My name is Alex Dodu. I come from the University of Ghana, where I'm head of clinical pharmacology, and I happen to be the president of all the pharmacists in the country as well. So I do a bit of finance. And my co-chair is...
I'm Socorro Zarate Escalante. I'm the technical officer and the medicines policy advisor at the WHO country office in Vietnam.
This session is on healthcare and financing institutions. As you've seen, there will be 3 speakers, each of 18 minutes, because we are slightly behind time. So without wasting much time, it's my pleasure to invite Saul Walker. He works with DFID. He's currently based in Maputo, and he's going to talk to us on a very exciting topic, win-win or lose-lose. Saul. He says you might do a little bit less than 20. Thank you, Saul.
So good morning, everyone. Firstly, just to thank the organisers for the opportunity to speak to you this morning. It's a great honour, and particularly with such an august panel here today. So I'm going to speak a little bit about a subject that actually has already come up, I think, in a number of the sessions, about the need to work with all the variety of stakeholders that together compose not just the pharmaceutical sector, but also the health sector more generally. And I think that's a really important message that we need to remember here, that when we talk about pharmaceutical systems, we need to put those firmly in the context of health systems more generally. So, see if I can work the technology. Where do I point it? So a brief overview of what I'm going to talk about. Firstly, when we talk about the pharmaceutical sector, there are a number of goals that we can have, and those are often in tension. That all of the stakeholders, and we often talk about the pharmaceutical industry as being irrational, but all stakeholders in the pharmaceutical sector can act irrationally with respect to the goals that we have. The weak health sectors really facilitate and exacerbate some of these irrational behaviors in the pharmaceutical sector. That the complexity of this system really means that we need to work dynamically with the different stakeholders. And unfortunately, there is no perfect resolution. It's not just a question of getting it right once and then everything's okay. We have to keep working at this, keep talking to each other, keep trying to address new challenges as they arise. So, importantly, I think when we talk about, well, what do we want to do in the pharmaceutical sector, we need to think about what we want to achieve. And as I said, I think it's important to put that not just in terms of medicines, but in terms of health sector goals and health systems more generally. So I've sketched out just a couple of things we might include as objectives for health, but also for pharmaceuticals. The top 3 really are sort of the outcome level, and I think probably fairly uncontroversial, that we want to see improved health outcomes, better quality of life for people, improved indicators across the board, really. We want to see patient and provider satisfaction, that the services that people get are acceptable, that they're delivered in a respectful way, and that really, that sort of demand side of healthcare is important. And that we want to see equity. We want to see the benefits of improved health systems spread equally across population groups, whether that's gender, whether it's socioeconomic status, and so on. I think more specifically for pharmaceuticals, we could probably also agree on the next set down: quality, safety, and efficacy of the medicines that we use, rational use and cost effectiveness. We want sustainable approaches to delivering medicines, and we want to see innovation as well. We want to have products that better meet the needs of people in developing countries and developed countries. I've put 2 more down the bottom, which often get thrown in and perhaps a little more controversial, but we want competitive markets. And we want, often you see this, and it's a growing demand in many countries, we want to see a local industry, or we want to see industrial policy get linked into pharmaceutical sectors. That's a more controversial topic, but I think it's certainly we need to recognize that it often influences decisions around pharmaceutical policy. And as I said, all of these things can be potentially in tension, and the different stakeholders, whether they be patient groups or local industry or private sector in terms of wholesalers or distributors or governments or donors, can stand in different relations to these objectives, and that relation to the objectives changes over time. So really just to emphasize that a little bit more, just some quite simple things that might be in tension here, that we want to increase the coverage of health services and access to medicines, but that kind of desire to increase coverage can be in tension with the level of care that we want to provide. There's a tension between the quality and standard of services or the technical level of services we want to provide and how broadly we can provide them. And of course, both of those things in terms of effectiveness of interventions and expanding the coverage are in dynamic relationship to cost. So there are trade-offs that we need to make there. And that's just in terms of the pharmaceutical outcomes. But if you add into that economic policies, external drivers like donor priorities, political cycles, and organizational politics, then these objectives become even more difficult to manage. I'm not going to dwell on the detail of this slide, but it's really just to emphasize the complexity of the health system and of the pharmaceutical system. This is a slide adapted from Dennis Rostegnan and from WHO, just to show the variety of different stakeholders involved, from governments, consumers down here, providers, third-party payers. What we don't have on here is really the supply chain providers as well, in terms of wholesalers and distributors. And we don't also really capture on here that the pharmaceutical sector is both international, national, provincial and local as well. So this does illustrate some of the complexity, but not even all of the complexity. Okay. And then, as I said, I think managing this complexity is even more challenging once we put that in the context of system weaknesses. And you'll recognize many of these weaknesses already that we have, often inequitable financing in countries, which might mean it's not possible for people to afford full courses of medicines or purchasing low quality products, for example. We have weak information systems, which makes procurement difficult and has limited use of information and evidence in planning. I've also put on donor practice in there as well, and I stand here as a representative of a donor organization, and donor practice can really make managing health and pharmaceutical systems in developing countries very difficult as well. So I stick my hand up partially to that. But the point here really is that given these systems' weaknesses, some of the things that we label as irrational behavior can actually sometimes be quite rational responses to working in these kinds of systems. So we need to think about pharmaceuticals not just by themselves, but in this broader health system context. So just thinking about some of those health outcomes or the ways that people might act irrationally, I just tried to sketch out here. It's probably a bit difficult to see, but just some of the ways in which these different stakeholders might act in ways that would be contrary to some of the objectives that we set out at the beginning. That country governments are always trying to manage their low budget allocations. They might have competing political objectives within the government, and we talk about a government as if it's a unified entity, but actually, if you're thinking about the Department of Trade or the Department of Finance or the Department of Health, often competing objectives within governments. Again, international agencies, WHO, UNDP, we heard already yesterday about some of the challenges of working with these organizations who also have their own agendas. They need to have visibility, they want to raise funds from donors and other things as well. Pharmaceutical companies we've heard about, but I think one of the things that when we talk about the private sector, often what we don't actually take into consideration is the complexity of the private sector within countries, thinking about informal providers, wholesalers, retailers. And actually, I think from the work that DFID has done in a number of countries, that part of the private sector actually has most impact in some ways on the availability and delivery of medicines in countries. And we really need to think through what we mean by the private sector in a much more subtle and complex way. But anyway, I've set out there how each of those different stakeholders might have or might act in ways that might be in contradiction to some of the outcomes that we want to have, and including patients as well. And you know, we recognize those kinds of challenges that they would have too. So one of the things that DFID has been trying to do with partners is trying to take seriously in this idea of working in a multi-stakeholder way. And I'm going to come on to in a minute one of the ways that we've been doing that through something called the Medicines Transparency Alliance, which really is was an attempt to take seriously this multi-stakeholder approach. So what would I mean? Well, what do we need to have a multi-stakeholder approach? What kinds of things do we need to be able to bring these different parties together in terms of improving health outcomes and improving our pharmaceutical sector outcomes? And I think we need clear goals and clear values about what we want to achieve in the pharmaceutical sector and in terms of the health sector. And I put values there as well, which I think is important. I said at the beginning that equity was one of the things that we might want to achieve with the health sector. But that's actually a value judgment. It's important to us that we spread the benefits of health across society. That's a value judgment. So we need to be clear when we're setting our goals and talking about our objectives, that we're clear about the sort of the philosophical and value judgments that underpin that. I put national medicine strategies as one way to set out those goals and those values. I've also put the National Institute of Clinical Excellence in there, which is a UK institution working on rational use. I put it there because it makes very clear that we're trying to manage the distribution and allocation of health resources in terms of product evaluations on the basis of a clear, transparent process within constrained resources. So it has a value judgment. Although it's very, very focused on transparency and evidence, it clearly is underpinned by a value judgment about how to allocate resources. We need to understand stakeholder positions and interests, and I put there politics with a small p and also with a big P. And by that I mean really understanding the different interests of the different stakeholders that we're talking about. And that can be as simple, well, not I say simple, that can be about organizational politics, what happens within a department or within a government, but also big politics with a large P, when that gets into political processes, democracy, and so on. So we need to really understand positions and interests and do that in a dynamic way. We need to agree some basic rules of the game. So how do we bring people together? How does debate take place when we're sitting around the table? What are the rules that are going to make that a rational discussion or a productive discussion? And I think that really includes the necessity of understanding that we can agree to disagree. We're not going to always come to some perfect consensus on how to move forwards on a particular issue. So agreeing that we can disagree, and meaning while we are disagreeing, that we still recognize each other as rational players and stakeholders that have a right to be at the table, is really crucial. And this will be a theme I think we come on to in a minute with Medicines Transparency Alliance, is the importance of information. We need better data. And I think it's been a theme through this conference that actually we often don't know what's going on. We don't have robust information. And I think that's important when we're coming to multi-stakeholder processes, because it's crucial that we can get away from whether your numbers are right or my numbers are right, and actually to focusing on what the facts are and then seeing how we can move forwards. So having robust methodologies to generate information is really crucial. We can identify opportunities for alignment. So that's the win-win idea from the beginning from the title of this presentation, is there are certain areas where we can get civil society, government and industry and the rest of the private sector to agree that actually it's in their shared interest to move forward. And I think quality is one of those areas, actually. Patients want good quality medicines. Governments want to know that the money they're spending on medicines is going to be effective, which means you need good quality products. And reputable industry, reputable suppliers want to know that if they're going to produce quality products, they're not going to be undercut by disreputable providers providing substandard medicine. So quality can be a key area where we can bring people together. Now, it won't always be that we can find these win-win situations. Sometimes we're going to have to balance and trade off opinions between different stakeholders. Sometimes we're going to have to persuade different stakeholders to participate in the process or in a way forward. And sometimes we're going to have to overcome disagreements within a multi-stakeholder group. So that's where the politics issue comes back into play. Crucially, I think we need to think about systems. A fix here can lead to an unexpected result over here, because these are dynamic, complex systems. So we need to be thinking about how the system as a whole works. And that's, again, why we need to bring these different perspectives from different providers, different stakeholders to bear, because they will see how our solutions or how our ways forward actually will impact on different parts of the system. And lastly, I think accountability is really crucial. It's fine to generate information, but we really need to have people responsible for that information, for actually using it and actually making a change. So the accountability aspect of this is crucial. And just to re-emphasize that we can't align everyone on everything all the time. So I'm not suggesting here that a multi-stakeholder process is going to lead to a simple resolution which for once and for all will solve all of our pharmaceutical and our health challenges. This needs to be a dynamic and ongoing process. I'm going to put transparency up as one potential area we can align, because I think there are opportunities here for the different constituencies to get benefits from improving transparency and quality of information. I won't go into all of these, but clearly in the international arena at the moment, there's a lot of focus on good governance and actually improving health outcomes. So better transparency about what's being achieved, better measurement of health benefits is going to be important. For the pharmaceutical industry, I think it's also important that accurate information on pricing, better procurement and forecasting can actually improve their business model. And I think a lot of the reputable organizations actually welcome having a better characterization of a market and being able to know that they're working in a fairer playing field. So I won't go through all of those. I'm going to move on now to talking about META a little bit. So META was the Medicines Transparency Alliance, was a program funded by DFID working in 7 pilot countries to strengthen transparency and accountability by sharing robust information in a multi-stakeholder environment. 7 pilot countries, Ghana, Peru, Philippines, Kyrgyzstan, Jordan, Uganda, and Zambia all took part in the program. All of them brought together and showed that it was feasible to have government, private sector, and civil society sitting around a table together. All of them were able to have work plans focused on improving and sharing information. All of them completed baseline studies that looked at the pharmaceutical sector, looked at the transparency in that sector, and all of them really began to share information and develop policy options together. 5 of those countries completed multi-sector working analyses, and actually I'll come on to that in a minute, but really looking at what that multi-sector process looked like, looking at the quality of it. And so what did we learn? It was a 2.5-year pilot, which is actually a very short time to try and bring these groups together and start to achieve things. And these are stakeholders that often haven't actually been used to working together. The dynamics varied by different country, depending on the strength of the constituencies, the familiarity with working together, and priority issues. But all of them did find things to work on. So in Peru, there was agreement on a pricing observatory. In Philippines, the constituencies worked together on an act on improving access to medicines. In Ghana, there was work on poor quality medicines in the supply chain that led to antibiotics being removed from the market. In Jordan, there was a new focus on standard treatment guidelines for hypertension. So different things worked in different countries and different alliances were formed. There were common issues, though, in all of the countries: the need for a shared vision of what we wanted to achieve, having ownership of the process within the country, having responsibilities about generating information and driving change, and then resourcing and communication to take the process forwards. The multi-stakeholder analysis showed that there were improvements in sector communication and participation, that people did actually begin to respect each other and recognize that the different constituencies had a right to sit around this table and work together. There are a number of abstracts here at the conference which you can actually follow up on. I've given the numbers there and gives more detail. But I'll just nearly finish now. So just this table here, and I'm not expecting you to squint and read the writing there. The most important thing there is to look at the green and the oranges. So this is really just to show that, this is from the analysis of the multi-stakeholder working, that this was a process that we started. The green is obviously where we made great progress, the orange is where there's still work to do, and the red is where there was little progress. But actually in these 5 countries, we did see movement and progress in getting these constituencies together and starting to work together. And on the basis of that, we have now, DFID has now approved a second phase of META that is really going to try and ask the question about whether we just bringing these people together and actually starting to work together can improve accountability and deliver better health outcomes, and whether we can move from just collecting data to actually driving change. And once we begin to drive change, whether this multi-stakeholder approach can still work. The International Secretariat for that is going to be provided by WHO, Essential Medicines Department, and High Global. So I'm going to finish there and just leave you with some questions. How do we build sufficient acceptance of basic rules to do this multi-stakeholder working? And for example, the concept of conflict of interest is different in a number of different cultures and societies. How do we work in weak health systems? Can the complexity and dynamism of the health sector and the pharmaceutical sector actually be managed? How do we balance short political timeframes with long solution lead times? It's something we're always grappling with. And how do we address the reality of power imbalances? All of these questions I think we're grappling with in many of the sessions while we're here for this week. And lastly, just to acknowledge the people who've provided comments on this presentation at the start. I'd particularly like to thank Anita and Dennis, who, while sending at least 20,000 emails to get you all here, also took time to comment on this presentation. And the META team here at the bottom, many of whom from Ghana, Philippines, Uganda, and other countries, are also here at the conference today. So I'll leave you there. Thank you.
Thank you very much, Saul. That was a great presentation, and we will come back to questions later on. Just a few comments. Now it's my pleasure to welcome to the podium the President and Chief Executive Officer of Management Sciences for Health, Dr. Jonathan Quick. Everyone calls him Jono. Jono?
Thank you, Dr. Dodo. Thank you, Dr. Escalante. Good morning. It's great to be here. I want to start by congratulating everybody in the room. Most of you have abstracts in this book or are going to be moderators or help make this happen. And this is an incredible wealth of intellectual effort, and it does take us toward informed strategies, effective policies, and lasting solutions. And I think it's really exciting. I also want to take a minute to appreciate a small group of activist clinical pharmacologists and others who in the late 1980s in a little town called Mannheim got together and hatched the idea for the International Network of Rational Use of Drugs, which led to ISIAM. It was visionary people like David Aforia-Jay from Ghana, Kamud Kafli from Nepal, Azad Chaudhry from Bangladesh, Johanna from Indonesia, not a clinical pharmacologist, but a clinical psychologist, nephrologists from Nigeria, people from Tanzania. It was visionary people like Hans Hogerzal from WHO, Jorn Thompson from Karolinska, people like Richard Lang from Zimbabwe. And the idea was to develop a new generation of people who didn't look at what medicines do to people, but what people do with medicines, that brought in the behavioral side, that brought in some of the other dynamics. And I would say that this book is, and what happens here is a testament to the success of that. The point I want to make is that we're at a point where we need a new generation that's looking at universal health coverage that brings together a different set of skills. It brings together the clinical pharmacology, but the economics, the insurance experts, and others, the supply chain people. And that's a new generation that we need to develop. Let me just acknowledge my co-authors in this, co-conspirators, Kwesi Egan from Ghana, and Anita Wagner, who's everywhere this week. Let me take us for a minute to northern Ghana. The year's 2000. Amina's a 28-year-old mother with 2 children, a third on the way. She needs treatment for her 5-year-old. She needs antenatal care. Her husband, Amadou, is a laborer. He has a hernia that needs to be repaired. For them to get all that done, they're going to need to sell 3 goats. And with a cash and carry system in Ghana, everything is pay. At that time, everything was pay as you go, and that put them at health risk and financial risk. They voted in 2000 for the new Patriotic Party, which promised to get rid of cash and carry and introduce universal health coverage. There's tens of millions or hundreds of millions of Aminas and Amadous whose health and financial well-being is threatened by the cost of health care and medicines. So the basic question is putting access to medicines and universal health coverage a golden ring? The merry-go-rounds, in the classic merry-go-round, there's a golden ring on the outside, and if you have enough reach, you grab that and you get a prize. Or is putting access to medicines and universal health coverage programs a Trojan horse that brings, with the Greek invaders into Troy, it actually undermines the success of universal health coverage programs. So we're going to talk about three things: out-of-pocket spending, the growth of the universal health coverage movement, and most importantly, providing access to medicines through that movement. Unfair health financing is a fundamental dynamic. This is, can I, oh yeah, there, well, sort of, okay. Let me just say, on the horizontal axis, you have the average spending from less than $10 per person per year in places, or less than 20 in places like Burundi, to well over 5,000 a year in places like the US. The vertical axis is the percentage of that funding which is out of pocket. And the double unfairness is that in countries spending less on health, much more is out of pocket. In the 33 low-income countries, over half of health expenditures, total health expenditures, are out of pocket. Places like Pakistan and Myanmar in the upper left, over 90%. India, 75%. They're spending roughly $100 per person, 75% of that comes out of the pocket of people. So it's unfair financing. That dynamic leads to health impoverishment. 150 million people are going to suffer financial catastrophe and 100 million impoverished because of this health spending. At the bottom is the percentage of total health expenditure which is out of pocket. And when you get over 50, 60% out of pocket, you see high rates of impoverishment. Finally, there's a healthcare gap. This is a slide from Tanzania that was part of the first wave of household surveys that WHO did. And it looks at what happens when someone got a prescription. High-income households, over 80% got all of the medicines, and 98% got all or most. For poor households, 1/3 of poor households got none of the medicines prescribed. That out-of-pocket dynamic has a huge health impact. So the growing movement for universal health coverage. Already, 50 countries around the world have a commitment and a formal program to provide universal health coverage. 30 of those are high-income countries, but 20 of those are low- and middle-income countries, and more are coming on board. The dark blue are programs that are already implementing universal health coverage. Mexico has been a leader, Ghana now, Thailand, and the lighter blue are those that have had a stated interest and are moving in that direction. So there's movement. The universal health coverage approach is not one solution. It's a set of principles, and these are key. Prepayment, contributions based on ability to pay from a variety of sources. Risk pooling, the rich to pay for the poor, the healthy for the sick. As it is now, it is the ultimate that the poor double suffer because they also are effectively taxed for their illness, and a goal of reduced out-of-pocket spending. So there's some principles. Countries vary a lot in how they fund it and how they operate it. So some basic principles and flexibility in implementation. There is now a movement growing. In 2005, somebody do the math. How far is that after 1975 when we had the resolution on essential medicines? 40 years? 30 years? You lose math when you're up front. 2005, there was a resolution on universal health coverage. In 2010, the World Health Report focused on universal health coverage. And in May of this year, the resolution at the World Health Assembly moved to put this on the UN agenda, universal health coverage, with a vision of moving from current 40% of the population in the world covered to 80%, and from a situation where 60% of health expenditures worldwide are out of pocket to have that. It's a vision, but it's moving. So what do we as medicines people do, and what's our role in this? What I'd like to do is actually introduce the whole question through 2 case studies. So the issue is medicines in universal health coverage. Is that the golden ring? Greater health impact, reduced medical impoverishment, and by having those benefits, making those programs more attractive? Or is it the Trojan horse? Does excess demand in these programs for high-cost medicines and some of the controls that are put on that, does it actually end up leading to financial threat to those programs and actually adverse health impact? So let's take 2 examples to see how this goes. A good friend and colleague opened up yesterday, Dr. Suet from Thailand. Thailand's been a pioneer, 50 years of movement toward universal health coverage. Didn't happen overnight. What you have here in the dark are the 3 programs that are in existence now. The civil servants medical benefits, the compulsory social security scheme for private sector employees, and universal health coverage, which gets almost everyone else. As of 2007, with this combination, they had 98% of the population covered. You can see in there some programs along the way toward that, which were consolidated in the universal health coverage scheme. They achieved the goal. This is a graph that shows the population coverage increase from 95 to 2003, and it's the percentage of out-of-pocket spending as a share of the total health expenditures. So it went from mid-40s down to under 25%. The 3 schemes vary a bit on how the 3 current schemes, the one in dark there, they all provide medicines, all out of the essential drugs list. But interestingly, the Civil Servants Benefits Scheme is a bit more flexible, has more provision for unlisted drugs, and the other 2 schemes are doing well. The Civil Servants Benefits Scheme, which is more flexible on their medicines benefit, has actually been experiencing some significant challenge. Between 1999 and 2008, the total scheme increased 300% in the cost. The largest driver in that, you guessed it, medicines, particularly outpatient medicines. Huge increase there. So, as often happens, they came back with some controls to try to catch up. That scheme was being threatened. The entire civil service benefits scheme was being threatened by growth in medicines expenditures. So they did what over and over again we've seen these programs do, introduce some audits, generic substitution. It wasn't enough in the first year, so in 2010 they strengthened that, and they managed in that 2-year period to get the annual increases from 15% down to 6%. So they got it back in control. Let's come back and revisit Amina and Amadou's country in Ghana. This infamous cash and carry, 2000, the New Patriotic Party wins. They did indeed, just before the next election, manage to introduce the National Health Insurance Scheme. It's financed from multiple sources. The main source is actually a value-added tax for health insurance, and they provide the services through a variety of accredited service providers, not just hospitals, but also down to the chemical sellers. And as we saw in Thailand, they did manage, by introducing this, to get a significant drop in the out-of-pocket expenditures for health. They did provide medicines benefits, financed through the National Health Insurance Fund. Interestingly, the National Health Insurance Fund medicines list is more expensive, it's more extensive and more expensive than the National Essential Drug List. It's got its own special list. The districts, as a result, need to provide access to hundreds of different products and forms. Anyone with a national national health insurance card and a prescription can be served. So what happened? Between 2006 and 2008, total claims increased sixfold. The orange is the total claims, the lighter orange is total claims, the darker orange is medicines claims. So claims increased sixfold total. Medicines claims increased 11-fold, so that medicines went from 25% of the total to 46% of the total. I can't tell you how many times in the last 15 or 20 years I've heard programs describe that same dynamic. Well, unmet need, you might say. Yes, part of that. Outpatient visits increased 50%, so some of it was that. But the average drugs per patient went from 4.5, which is already a lot, to 6, and the average cost went from 90 cents per person to 360, so a fourfold increase. What's the impact on the Ghana system? By 2008, the NHIS owed the districts $34 million in reimbursements. The delays had a knock-on effect on the district revolving drug schemes, quote, crippling levels of indebtedness, such that NHIS members were actually were asked to pay when they went because the district couldn't afford it. This is a textbook example of the Trojan horse effect. So here's a blueprint. How do we get the golden ring and avoid the Trojan horse? And I'm not going to go through all of this, but just a couple of key points. The upper left, medicines, benefits, and use. I would argue that some of the best examples of rational drug use occur in universal health coverage insurance schemes that actively implement the essential drugs concepts. But we have to do it in a way that gets value for money and really looks on the upper right there at some of the therapeutics. The payment mechanisms, this is where the economists come in, because some of the payment mechanisms, particularly the cost sharing, decreases use of needed medicines and have a negative health impact. Some of the provider payments actually improve the efficiency, some actually lead to cost increase. And on the lower left, the performance management, if we're reimbursing medicines provided through an inefficient system, we're subsidizing inefficiency. That's where the supply chain people come in. So we've boiled this down to 7 best practices for proposed. They're still a work in progress for maximum health impact and value. Some of the obvious things: stakeholder engagement, smart therapeutics, really using our lever for efficiency, reliable partners for every part of the program, and looking at performance management. There are some common threats. The competing political goals come up over and over again. This dynamic of having because there's money behind it, everybody argues to get more drugs on the list, advocates for more expensive use of those. Number 5, failure to utilize needed expertise. What happens, these programs are often designed by people who have expertise in one of those 4 boxes on the blueprint, but they don't get all of them. So it really needs to be working together. Failing to keep up and manage growth. The catch-up that we saw in Thailand and Ghana is classic, where the program gets ahead and gets financially jeopardized. So, in summary, out-of-pocket expenditures are the driver of health worldwide for particularly low countries, low and middle income. It has a huge health risk and a huge financial risk. The universal health coverage movement is on the way. Medicines benefits are a big part of that. There's some research issues that we really need to address. And we need expertise from multiple disciplines. It's not just that it takes a village, it takes a university of all these different areas of expertise. So here's Amina and Amadou in 2011. Miraculously, she's still 26. but she's got her medicines covered and the surgery covered. She's really happy she voted for the new Patriotic Party, but she's really worried because she's heard what's happening, and she's wondering if she's going to have to wait for the 4th Isseum or the 5th Isseum in order for the lessons to be learned that her president and the people running her insurance program need in order to be sure they have a program that is affordable and sustainable for health impact and to protect them financially. So I would really like to see us begin to create a new generation of the medicines community that can address this issue. And you have your first opportunity Friday morning at sunrise. There is a gathering of people interested in health insurance coverage and medicines in the Ezra. And there are a number of different programs and more how-tos, including the chapter from the latest electronic managing drug supply. So thank you for your attention, and keep Amadou and Amina in mind. Thank you.
Thank you very much, John. We would now like to call on our third speaker, Ms. Maryam Bigdeli. She is the Technical Officer of the Alliance for Health Policy and Systems Research at WHO in Geneva, and her presentation is entitled A System Framework for Access to Medicines, Implications for Research and Policy. Maryam.
Thank you, Saul. While waiting for my slides, I would like to say it's extremely difficult to speak after Jonah Quick's inspirational talk and example of Amina's story. We have heard in the past couple of days a lot about the need to have a health systems approach to access to medicines. I hope that the title of this presentation is not going to raise too many expectations from you, because this is just a work in progress and my humble contribution to this debate. Technology. The outline of my presentation, I'm not going to present about the current station and future challenge of access to medicines, because this has already been done. But I would like to try and draw a multi-layer health system view of access barriers and try from that to derive a system framework for access to medicines. We will not talk about stakeholders, because everybody has done that very well in this panel, but we will talk about implications for research and policy. What we need to remember is that we have had a fragmented vertical approach to access to medicines, and that there has been a disconnect between the pharmaceutical and the other building blocks of the health system, as they are described here in the WHO Health System Strengthening Framework. But the idea is that we do have ongoing challenges in access to medicines, new challenges that everybody has described, and definitely new opportunities, including with universal coverage. So how are we going to try and face these new challenges and seize these new opportunities? Not by tackling access to medicines in isolation within a health system, but by trying to actually harness multiple and dynamic relationships between building blocks of a health system. We have tried to draw a picture of multi-layer health system barriers to access to medicines. We have used the work from Kara Hansen and colleagues, which in 2003 have defined a framework to categorize access constraints in a health system. And they have said that access constraints can occur at 5 different levels in the health system: at the individual, household, and community level, at the health service delivery level, at the health sector level, but also beyond the health sector at national level, with public policies cutting across sectors, but also at the international level. We've done quite an extensive search of the literature to try and find barriers and categorize them in these 5 levels. Please do not try to read this table. This is just to demonstrate that barriers to access to medicines are multiple, and they occur at these 5 levels of constraints. These are not new barriers, we all know them, but to lay down the fact that they are actually occurring at those multiple levels is interesting to try and have a real health system view on access to medicines. In the past, there has been several frameworks that try to address access to medicines. For example, WHO and MSH in 2000 convened a meeting in Ferney-Voltaire and tried to define an access to medicine framework based on the work of Penchansky and Thomas. This framework, really useful, is actually mainly addressing barriers at the health service delivery level and with the interaction between the service delivery and the user, the interaction with the patient. In 2004, there was the WHO, the very famous jigsaw puzzle, Equitable Access to Essential Medicines framework. This framework, also extremely useful, is addressing barriers at the level of the pharmaceutical and the health sector. Indeed, we seem to lack a framework that is really addressing the multiple layers of the health system that we face every day. To be able to try and start drawing such a framework, I would like to propose 3 paradigm shifts. The first one is to adopt a holistic view on demand-side constraints. This holistic view would need to go beyond the individual user, the individual patient, one separated from the other, but be inclusive of households and communities. The second is to try and consider the multiple and dynamic relationships that occur between building blocks of a health system. And the third is to try and consider a multi-layer leadership and governance that goes beyond the health sector, but is inclusive of local, national, regional, and international context. Yesterday, in one of the parallel sessions, one of our moderators said that paradigm shift was a buzzword. And he asked us to actually define acronyms and buzzwords that we were using. I tried to comply with this requirement, so I searched paradigm shift yesterday. A paradigm shift is a change in the basic assumptions within the ruling theory of science. This is from the Structure of Scientific Revolutions, dated 1962. In layman's word, it means that we need to think outside the box. But as I am a trained pharmacist, I like to put things into neat boxes and preferably adequately labeled. So this is put in boxes the 5 levels of constraint that operate in a health system. Let's talk about these 3 paradigm shifts that we would like to put into these boxes. At the individual and household and community level, we really need, as I said, to go beyond the individual user and try to adopt a holistic view of demand side. Yesterday also, Professor Klaus Lesinger presented the framework by Obrist et al. That says that this framework says that individual patients actually are within a household and a community in a vulnerability context, and that they have a set of 5 essential capitals: physical, natural, social, human, and financial capital. By augmenting these capitals, we will actually be able to harness the resources that are available at community level and use these to improve access to medicines. For example, through expert patients, through payer-educator networks, through community networks, and civil society organizations are really essential elements of a paradigm shift for the demand side. Then I would like to open the box, the little neat box of service delivery, and look at the other building blocks of the health system. Medicines are indeed an input to service delivery. We need them to be able to deliver services. But there are other inputs to service delivery: health financing, human resources, health information, and health service infrastructure. Actually, all these inputs are tightly interconnected in multiple and dynamic relationships. I will just give you one example of this. We always say that we need budget for medicines, right? We need money to be able to purchase medicines and deliver these to patients. But actually, we often forget that medicines are a source of income for service delivery. In the Bamako Initiative and cost recovery mechanisms, we have set up medicines to actually be sold to bring funding to service delivery. and to be able to purchase more medicines. So actually the relationship is twofold here. Other multiple dynamic relationships can be demonstrated with other building blocks of the health system. I will not go into the details here. Now, the box of health sector is inside the box of national context, which is inside the box of the international context. What are the determinants of access to medicines in these national and international contexts? Here are 4 elements that I have written down here. Well, there may be more, and I really would value your comments and contribution to try and spell out better what are the determinants of access at these levels. I think market forces are extremely important. We've talked about them. The informal sector, the private sector, the trade and economic goals that actually may be conflicting public health goals. The second determinant is innovation. Innovation in new medicines, but also new formulations, new combinations, new packaging, and new delivery channels. The third is transparency on price, source, and quality, but overall accountability of the system and overall social contract that we have. The donors, especially in countries where there is an over-reliance on external funding, or a reliance on external funding, can't say over because that's needed. Indeed, donors have their agenda, their funding streams, and whether they're harmonized or aligned is important with regard to access to medicines. To be able to make this system work, we need governance. And this governance will need to occur at multiple levels, not just the governance of the pharmaceutical sector, but a governance of at the national level and the international level as well. Well, I am not in a position to actually try and define what an international governance should be. Is it WHO? We heard yesterday that some people are skeptical about that. Is it another agency? Is it a compact? I am not an expert in this field, but I really would urge people to actually think about that idea. So let's stop here for a minute. I think I know what you think. I think you think that I'm out of my mind putting in front of you a structure like that with arrows in every direction and say that we need to try to build interventions and policies that actually take into account all of these interactions. But let me just draw a parallel. In the last century, we had penicillin. And we thought that with penicillin, we were going to kill every single little bacteria that was going to kill us. But actually, a century later, we find out that to be able to do that, we need broad spectrum antibiotics in complex formulations, because the bacteria in the complex system that is our human body has actually adapted and resisted. Complex system adapt and resist. Simple interventions are not going to be able to take into account of the adaptive nature and resistive nature of complex systems. Just as we need now to come up with broad spectrum antibiotic in complex formulations, we need to come up today in front of this complex health system with broad spectrum interventions and complex formulations. I'm sorry, but this is the reality that we face. I'm not going to talk about stakeholders because others have done that very well, but very quickly, implications for research and policy. Of course, this complexity, we cannot face it all in one block. We need entry points. We need to use entry points to be able to work on this system. But while doing that, we need to keep the wider picture in mind. What are the contextual prerequisites for a given policy or intervention to work? What are the wider system effects on other building blocks when we have an intervention on medicines? System effects on financing issues, on the health workforce, extremely important. What are the information requirements, and so on and so forth? And how will the system react? Try to think one step ahead, as we must have thought one step ahead when we used and overused antibiotics. First line. So a system perspective can minimize the mess and many of today's problems because of yesterday's solutions. This is a quote from Dr. Irene Agipong from Ghana Health Services. A collective systems thinking exercise is required among an inclusive set of stakeholders. These inclusive set of stakeholders, well described by Saul and by Jono, have to come together, revisit current policies and interventions, and think how successful are they really beyond the immediate effect, beyond the flash effect that we may see. And Kathleen Holloway yesterday really presented the long-term vision that we have on our interventions and the fact that it is a little bit of a depressing picture. So revisit them and then try to think how could a system-wide perspective reach longer-term and more sustainable result, and then use this opportunity to redesign. I would like to thank you for your attention for this little bit tortuous presentation. I would also like to thank my co-authors of this framework that will hopefully soon become a paper, Bart Jacobs, Richard Lang, Joran Thompson, Abdul Ghaffar, Bruno Desjardins, and Wim van Dam. I would like to acknowledge for their valuable comments Anita Wagner, Ken Ranson, Tagreed Adam, and Lucy Gilson. And if you're interested in health systems, I would like to invite you to Beijing between the 31st of October and 3rd of November 2012 at the Global Symposium for Health Systems Research. Thank you very much.
Thank you very much, Maryam, and thank you very much to all the speakers. We have 3 key questions, but I guess the speakers would not have the time to answer them now, but we are going to nevertheless mention them, and maybe the answers would come in the ongoing discussions and on the online discussions. So the first question is from the audience, and it says, we strongly support the system approach to ensure universal access to medicines. The question is, what are the boundaries of such a system and the main partners at the national level? What is the role of the professional societies, the interest groups, and the academic research centers? The second question is for Saul. We know that the Medicines Transparency Alliance has been implemented in 7 pilot countries, and a lot of work has been done at that level. It would be interesting to know what are the key facilitating factors that has stimulated the establishment of the multi-stakeholder collaborations in these countries. And more curiously, what has been the role of the industry as a member of the multi-stakeholder collaboration in stimulating transparency and accountability in the pharmaceutical sector. For Jonathan, we know that developing countries are more vulnerable to the effects of the Trojan horse, considering that regulatory frameworks and monitoring systems are very weak, and what could be the tools that could be used for developing countries to monitor such adverse effects and to alert them early that something has to be taken immediately to correct such unintended effects. For Maryam, we congratulate you for the ATM research. We saw how she worked with the different countries from scratch, and we are now seeing the results. And the question is, how do you plan to move this forward into the policy areas, and particularly to bring this to the attention of the donors, to make them address the barriers on access to essential medicines in the implementation of the program? So we hope to get some of your answers in the ongoing discussions. Thank you very much for the excellent presentations and for all the work that has gone ahead of your presentations. So we are now going to pause for a break and invite the participants to go to the breakout sessions. Thank you very much.